I think we can probably start. So welcome everybody to the very first seminar of the term. I hope you've all got the program for the term, and if you can't find it, you can either look on the departmental website. If you don't have access to it, just drop myself or Gemma a note, and we'll send you the program. So today, which is the first seminar of the term, is going to be hosted by Tony James and Rachel Hogan, and they're going to be talking about giving us an update on the adolescent treatment-resistant depression clinic, which they've set up here, which has been really successful and very important. Tony James is a consultant child and adolescent psychiatrist and doesn't need much introduction. But just to introduce Rachel, I think many of you will know Rachel, but not everybody. So Rachel is the clinical lead pharmacist for Oxford Health NHS Trust and has worked in mental health for 18 years. She established the Trust's Medicine Advice Service and has been responsible for formulary and guideline development. And she's focusing now very substantially on child and adolescent mental health services. And she works in the MDT clinic at the Highfield. So we welcome Rachel and thank you very much for joining us. So Rachel and Tony, please go ahead and give us your talk. Thank you.
Well, thank you very much indeed for inviting us to talk. First of all, I've got to say that Rachel is the brains behind this and done most of the work. So thanks to her. I have some slides to show. So it's myself and Rachel, and we set up a treatment resistance clinic. The question really there is, what can we do? And the answer is quite a lot, but obviously you have to be informed. So this talk really is going to, first of all, just briefly refresh us all about what we know about depression, and then we're going on to talk about treatment-resistant depression, which is not straightforward, and Rachel then will give details about the actual clinic and the runnings of the clinic. So many manifestations of depression, as you can see from these kind of diagrams here, and we've got to remind ourselves that we're not just talking about depression as a kind of transient mood state, we're talking about a syndromic problem as diagnosed in DSM-5 criteria, which talks about depressed mood and constellation of symptoms there, which you can see, including risks of death and suicide. So yes, it occurs in children, interesting enough, and probably equal sex distribution in childhood, but a higher distribution in females and a higher rate in adolescents. But there you see something quite worrying, a cumulative incidence about 1 in 5 by the age of 18, which may be difficult to understand, but I'll show you a slide later on to explain that. Indeed, this is more recent American data showing that obviously mild depression is less common, more common than severe depression, but the rates of severe depression are between 3 and 2.3% for males and females in the United States. So this is just a summary slide here talking about severe depression. And the interesting thing which we borne out in the clinic is that really you do not see pure depression. It's often comorbid. And the more severe the depression, the more likely you are to get comorbid problems, including post-traumatic stress disorder due to trauma often, or trauma, sometimes sexual trauma, anxiety being one of the most common comorbid disorders, and so on. But you look across the broad range of children's problems, and anxiety disorders are probably the most common early and occur early. Disruptive disorders, then in adolescence there seems to be a pickup in depressive disorders, and that's just from the Oregon study some time ago now, just rather confirming that. But this is one of the important slides really, really highlighting, as in Nature Review this week, just how important child and adolescent psychiatry is, and psychology, and how neglected it is, which is really bizarre, because if you look at this, then it's crystal clear the onset of depression is in childhood and adolescence, and it wanes thereafter. So, but it is, unfortunately, once started, can be a chronic illness. And these are the sex differences in a more recent paper and cumulative incidence there, which you can see, and occurring more frequently by the age of 12 in females, with cumulative incidence there, which is really astonishing. Now, the interesting thing is work from Ht1 Agonists, who's now retired but was in the United States, showing that it's really puberty is the issue that leads to the onset of depression more in females than males, and maybe a whole host of reasons for that. It could be social, it could be biological in terms of hormonal and so on, things, but it's not age, it is sex, it is in terms of gender, in terms of pubertal status that seems to be the trigger for the onset of depression. So is it important? Well, yes, it's obviously important. These are 2013 paper in The Lancet, looking at disability adjusted life years for each mental disorder, and depression trumps everything by miles. So it's really an important disorder and probably recognized but undertreated. Well, it's very difficult to treat, I think, is the answer. So do we have guidelines? Yes, obviously we do. And it's very important, this. I think Dick Harrington was one of the first persons I knew to talk about tier 1, importance of just watchful waiting, triage really often, and maybe psychosocial difficulties can be adjusted if it's bullying, difficulties at school, or family problems or relationship problems. That does not necessarily require mental health input, but obviously there are treatments that actually can help the tier 1 and tier 2, and then we can move towards psychological treatments. And the question then for more moderate and severe depression, actually psychological treatments plus pharmacology, and more severe, then it'd be pharmacology perhaps first. But these are nice guidelines which I think we should adhere to. They've been researched and sensibly guided, and you see there, which is quite interesting, tier 3 and 4, intensive psychological therapy for those who are unresponsive, fluoxetine, sertraline, citalopram, augmentation with antipsychotics. So it's one of the few guidelines that actually gives you an idea of what to do if you meet some degree of resistance. Just going back over stuff which most of you know in terms of what the treatments would be for the first kind of treatment presentation, brief psychosocial intervention. And this is actually quite important for our clinic in terms of we can advise on psychosocial, we can advise on pharmacology, but we clearly, it's not enough, and we'll show you later on, it's actually psychological input, even if it's brief psychological intervention, which is shown to be as useful in the ADAPT study as other forms of psychological intervention. And it's relatively straightforward: psychosocial, psychoeducation, healthy habits, exercise, and sleep, and so on things. But actually getting people to do these things, valued activities and things like that, is very difficult, especially exercise and eating well and sleeping well. But they're probably vital. And digital CBT has now been shown to be actually helpful and is recommended in NICE guidelines. So that's for the other end of depression. And this, I think, is very helpful. You'll have the slides later on to talk about the how one tackles the depression. And if you look on the diagram there, you can see how it starts off: depressed mood, anhedonia, feelings of worthlessness, and then suicidal ideation. So it seems to be gradation. And one of the things I think for a talk like this, which we need to be clear about, is that depression is syndromic, but it's really unhelpful, I think, to just talk about depression as if it's a unitary phenomenon. We need to be talking and breaking it down in terms of, does this patient have anhedonia? There's a guilt there, or self-blame, and so on, things like that. Some of our instruments, and I think there's a talk next week in the department about, are we missing something by just talking about the BDI and not breaking it down into anhedonia, which actually has implications for prognosis and also treatment. But you can see there's gradation there of this going down: weight loss and weight gain, psychomotor retardation. And along the other side here, then, if we look at what the treatments can be, psychoeducation, low intensity intervention, going across to actual interventions that CAMHS might be offering, cognitive behavioral therapy, interpersonal therapy. As far as I understand it, interpersonal therapy is probably as effective as cognitive behavioral therapy, but doesn't have such a marketing appeal. So it should be interpersonal therapy, cognitive behavioral therapy, mindfulness as well. And the first line treatment is, as we know from NICE guidelines, fluoxetine, and others will talk about this there. And of course, for the very severe, there is more interventive treatments, including ECT. And the strategy which falls in the middle of those, which we're going to talk about today, combined pharmacotherapy and psychological therapy, which I think should be the mainstay of a treatment we offer in CAMHS, and the things that follow on from that, if one's not making headway, increase of antidepressants medication, augmentation with possibly T3 or antipsychotic medication or lithium, and combining antidepressants as an option. Now, you could say, and I think the Wellcome Trust have really taken a bit of a downer on our treatments of depression, say, wondering whether we need to rethink things from scratch as we're not making much progress. But the treatment is extremely complicated. And if you just look at the synapse here, one can see a massively complicated pre-synaptic neuronal differences or interventions, post-synaptic, and including neurogenesis. So where one intervenes is really quite important, and there's an interesting kind of play here in between where one can actually and where one shouldn't intervene, and the combination of medications that you can look there. So you'll have these slides later on, so you can see this melee of where drugs work and where one can actually see changes. So, all right, so that's okay. So we understand then that the action on a synapse is complicated and probably interlinked. Do these medications work? Well, this is one of the papers with Zhu and Andrea Cipriani in Lancet. An updated review is a network meta-analysis looking at depression, psychological treatment and medication, the combination. And I just put this up here, you don't need to read this really, but actually said only fluoxetine plus CBT and fluoxetine was significantly more effective than pill, placebo, or psychological controls. But they were effective. And it says the high quality evidence was rather scant. But we do have something. So it's not, and when I offer treatment to people in the adolescent unit or elsewhere, then I do point out the caveats that the evidence is not strong, but I'm not quite clear whether the evidence from the trials really matches our clinical workload all the time. Dick Harrington in the impact study was quite clear that actually he wanted just to take anyone who's depressed, and so there's real world data. But some of the other trial studies, the TRD studies and things like this, excluded patients who were suicidal, so it doesn't represent the real world. So this is the outcome of this in network meta-analysis, which is the blue one representing efficacy and the red one accepting acceptability. So those two parts are important to look at. But again, most of the work's been done on fluoxetine. There is difficulty in some trials that actually may well be important, being withheld by big pharma, but well, maybe we'll come to that later. But these are the pairwise kind of meta-analysis here, showing that CBT and fluoxetine actually shows imipramine up there quite a bit, but we find that actually imipramine and tricyclic antidepressants in general are not recommended and are dangerous, so we do not use them. So what is treatment-resistant depression? Well, you may be surprised, but there's no consensus on that. But we think that probably the one that has the most traction is this failure to gain remission with 2 or more adequate antidepressant trials. And it does have to be, and I think some people will put on a caveat at the bottom, with psychological treatment. So, well, does it matter? Yes, it does, because the prevalence of resistance is actually quite high, at least 20%. We've done a survey here and showing that people who've had multiple switches of antidepressant medication, possibly because they're not working, is probably about 30%. And it's actually quite difficult to predict who's going to be the most not respond, but there are probably two aspects that do contribute to some degree of resistance. Family history of affective disorder, which kind of makes sense, maybe genetic predisposition there. And the other one, which I think is important to show, that there is a psychosocial aspect to this, an adolescent's degree of cohesion with his or her group. And that's important, especially in risks of self-harm and suicide. And probably something that we do know, and probably all practicing clinicians will know, that child sexual abuse and things like this is an indicator of poor treatment response, as it is in many disorders. It's not specific to depression. So this is from the Journal of Biological Psychiatry, suggesting about 30% of depressive episodes not respond in first-line treatment. So what do? Well, you can maximize the dose, and I think that's actually quite important if one can. And I think that one has to be not bullish, but quite firm in your as a clinician to make sure that people are taking the medication and taking it well. In the TRD study, 30% of patients didn't respond because they weren't taking the medication. And one of the things that Rachel and I discussed is actually being clear with patients and the clinician looking after them to make sure that patients are actually taking the medication, whether they need to have a pill count or reminding, because people don't like taking medication naturally. But actually, I think the biggest contributor, I think, may well be people just not taking it. If one is clear the patient's taking the medication, switching to another antidepressant has some evidence to read a study here. And we're talking about the types, so you can do that. And perhaps switching to another type pharmacological class. So you may well wonder what we can do here. So two antidepressants of different classes, SSRI or mirtazapine, or a dual-acting antidepressant. And then augmenting with other agents, which has some evidence, and I'll come to that in a minute. Lithium, thyroid hormone, atypical antipsychotics, probably atypical antipsychotics, the easiest of those to think about. But it's got here, combining antidepressant with psychotherapeutic intervention. There's evidence that actually psychotherapeutic intervention is important in all types of depression, and probably ought to be thought about earlier than indicated in this slide here. But if there is continued depression and risk of to self, then there are bright light therapy, exercise, things like that. But if not, then biological treatments, including ECT for very severe depression where there's a risk of suicide. That's quite rare. I think we've only give ECT for depression possibly once in 2 years, probably even more, less frequently than that. So this is just giving you the idea of what antidepressants and antipsychotics we use. Aripiprazole, quetiapine, combined with antidepressant psychostimulants. Perhaps lithium has the most evidence, I think, but there's giving you some other ideas there. I'll mention ketamine because that certainly would be a consideration. Is regarded as a game changer, and I think if Federico's listening on now, he would talk about the possibility of ketamine clinics breaking up all over the place. And I think Professor McShane's quite concerned about this, that in states people have a walk-in kind of ketamine clinic before going to work. Well, this is not exactly what one wants, but it is clear that actually there is a quick, immediate antidepressant response. We've only ever used it in one case of a young person here with treatment-resistant depression. And it did look like a pure depressive disorder, though events probably panned out that there's more borderline features to this and family difficulties. But at the time, it certainly looked like a pure depressive illness, unremitting. And we were considering ECT, but actually went for ketamine. And I was surprised for the first 3 times she had a dissociative episode, which indicates the therapeutic dose, but no response. And then the 3rd time I was walking down the corridor and there she was, and saying, "What's the problem? Where's the fire?" I mean, it was just complete transformation. It didn't last for long, but it was enough to show that actually the treatment, there is a possibility of a change, which she didn't believe before. So ketamine, yes, rapid effect, reduces suicidal ideation, and they're saying single dose can provide mood benefits over a week perhaps, but you have to have the dissociative symptoms, and that I think is quite a worry, because you tell patients you are going to feel unreal and in an altered state of consciousness, and I think that's all right perhaps to talk about in abstract, but if you know that you're going to go through that, the question is, are you going to come out of it? That's what the patient said to me. And yes, of course you do, but actually it would be a horrible idea to think that perhaps you didn't. And some patients have taken illegal drugs and started a psychotic episode from which they've not recovered. There is a risk of abuse potential. And the way that I think Professor McShane does it here is as a medical intervention. So it's actually IV introduction. So we know the dose. It's not likely that that's going to perhaps lead to such a risk of abuse potential, but we'll have to see. So yes, there is some evidence, mostly open studies, as you see here. And we have biological evidence of where it works in terms of imaging, as well as the self-report and others report in terms of mood. But ketamine actually has a complicated pharmacology and pharmacological effect, really. And yes, it works through NMDA glutamate. But interestingly, if one blocks, and I'll just go to the next slide and come back to this, if one blocks 5-HT1A with an antagonist, you completely lose the antidepressant effect and acute and sustained antidepressants. So that it does seem that, all right, so it works through glutamate and things like this, but actually it works through serotonin. So that fits with our evidence of giving serotonergic antidepressants, but so they're interconnected, as we probably know. So these are the 5-HT1A agonists, buspirone, which we've had for some while, not widely used, but certainly something that should be in the armamentarium TRD clinic. Aripiprazole as an antipsychotic, but also 5-HT1A receptor agonist. Vortioxetine, which Rachel can give some information about. The other medications I don't have experience of. Now, the interesting thing is that when I went to the ENCP conference a few years ago in Copenhagen, there was talk about a specific biased agonist antidepressant that works on the frontal cortex there, a 5-HT1A receptor, which is completely selective. If you look down here at the Referral, serotonergic agonist there will actually decrease your antidepressant response. So it may be there's a whole host of reasons why antidepressant treatment takes some while to come into force, but actually it's much more complicated and nuanced in that actually in one area of the brain it actually leads to antidepressant response, in another area it is actually antagonistic. So that's interesting to take into consideration. So what we want in looking at this diagram here is specific biased agonist. And actually we have one that Catherine Harmer has very kindly taken on the research with NLX 101, which has been shown in mouse and in rats and some human trials to have specific effect on the GABA interneurons in the frontal cortex, and affecting glutamate transmission in a highly selective way and rapidly, so that we would have an antidepressant that's oral, that's safe, has few side effects, and activates a pathway that ketamine does, but without the risks. And that is the goal. Well, that's a gold trail. So This is a kind of systematic review. It's all over the place with low cases, a number of cases, 2014. But there's a better study review with all age groups, with adults as well, showing that the effect sizes on the bottom here. So short-term treatments, well, they small side effects there. Psychological placebo having so clearly there's some witch doctoring here. If you can do psychological placebo, that works. Pill placebo works too. Psychological therapies do work and actually have a moderately large side effects there. But the trouble is, as you see, very wide confidence intervals there. But the things we're talking in terms of pharmacology, antipsychotics, mood stabilizers, that be lithium, and MDA target agents such as ketamine. And this is from that paper. You can see here lithium, the effect size of 1, antipsychotics, particularly aripiprazole, 1.33. So really, but psychological therapies, which I want to emphasize, really do have an effect, but perhaps to not such a great degree, but there's no reason why they can't be combined. Maybe the slide should have come a little earlier, but when we're talking about the response and what dose one needs to give, this is a paper with Furukawa, who's actually a colleague of Andrea Cipriani. You're showing here that actually the maximum effect for fluoxetine does seem to be about 40 milligrams, but if you actually look then, the dropout rate increases quite considerably due to adverse effects or just dropout rates. So probably you can go up to 60 milligrams, but the side effects do seem to increase with dose. And the other treatments which you can look at, deep brain stimulation, which we don't do, but may have some evidence there. Bright light therapy uses an adjunct, and patients can buy these or parents can buy these. It certainly doesn't help. TMS, which I am not sure whether that's available readily in the trust. So this is not registered in Poland. That's where this paper comes from. But ECT is effective and actually has few side effects relatively, given the severity of depression. Psychedelics, I've given the PMID number there for this papers here, but psychedelics actually work with neuroplastic effects here. All the ketamine, psilocybin, and things like this all have an effect upon neuroplasticity and dendritic spine formation and axon branching. So that's quite interesting, but also have anti-inflammatory responses as well, because one of the routes into depression may well be an inflammatory response. And they all have an effect upon neurotransmission. Psilocybin there, striatal dopamine transmission is increased, whereas ketamine is much more broadly there. So actually this is probably something that we need to be looking at more widely. There's evidence recently showing that psilocybin is a good antidepressant, but we're waiting larger trials. So I'll leave that there for the moment, if that's okay, and hand over to Rachel.
Thank you. Okay, I'm just going to see if I can share my screen.
You can see it nicely now, Rachel.
Is that working?
Yeah, perfect.
Okay, brilliant. Right. Okay, thank you for the invite to come and speak here. I've just got a handful of slides about the clinic itself, how we set it up, how it runs, and just a little bit about how it's gone so far. So earlier this year, we came up with the idea of setting up this clinic, and with the idea of being able to help support CAMHS clinicians within Oxford Health to kind of look beyond what the treatments within NICE are. We designed it as a consultative model, so that we weren't, we're not taking on the caseload of clinicians, and we set up a number of referral criteria, which basically are based upon what Dr. James has been saying about treatment resistance of failing to antidepressants, but also with evidence of psychological treatment. And so we would take referrals from CAMHS consultants in the adolescent age range. And we developed various things with this model and took the proposal, which was given an approval to pilot for up to 12 months. And we advertised to CAMHS consultants via various means, including a video that we produced, which was an interesting experience, slightly cringy. So I'm sure some of you listening may have watched that and hopefully received some of the advertising that we developed. So the way the clinic works is that we have an online referral form which gathers some fairly basic background detail, but allows us to see whether the patient fits the criteria for treatment resistance. So those online referral forms come to us, and if they do fit the criteria, we then arrange with the consultant a Teams meeting, but to have a discussion. Prior to that, though, we also send out the development and wellbeing assessment tool, so that the clinician that's requested the consultation can forward that on to the parent and young person to complete. So that's an online assessment, which we then are able to see and produce a report for, that's shared with the clinician before the discussions. Can be quite a useful tool. And I also carry out a medication kind of review of the patient's notes in advance of the scheduled meeting. So the meeting currently has just been with the consultant, not the patient, but has also sometimes involved a care coordinator or other member of the team that's looking after the patient as well. So during that consultation, we basically put our heads together. It's not us telling you what to do, but it's really trying to look and drill down and kind of holistically assess what may be useful to consider. So we, with our heads together, kind of come up with some recommendations, a bit of guidance, some suggestions, and that's all put into a report at the end that gets sent by email afterwards. And we also did produce a number of pieces of sort of supporting materials, mostly around the possible medicines that we might be recommending. So there's no real specific formula that we follow in terms of what medicines we recommend. Obviously, there's ones that Dr. James has kind of mentioned. Various options are kind of tailored to the individual. So it's not, you know, if you tried 2-SSRIs, you try this next. It's completely patient specific and based on the case and what we're seeing. So we do have clinician medication information sheets that we send out for things like vortioxetine, duloxetine, etc. And we offer repeat appointments with the clinician if they want them. So it's kind of left up to the individual and what is needed, and they can get back in touch with us, and we can schedule more meetings as needed. So the clinic's been running since February, so about 9 months now. We haven't had huge numbers of referrals, 14 in total, 5 of which were not actually seen in clinic, 3 because they didn't really fit the criteria for treatment resistance. But we did separately provide advice over the phone for each of those 3, and that was kind of following discussion of the case briefly, and looking at what else could perhaps be tried first. And so possibly some of those may come back at a later date, and we will see them through the clinic. So we've seen just 9, given 9 consultations, a couple of those with several repeat follow-up appointments as well. And it's been interesting and probably not surprising. They were all quite complex presentations, none with just pure depression. Most, I think, were 15 years old. I think that the majority were, and quite a high proportion of cases had comorbid ASD and various other things also going on, emerging personality disorders. I've listed a few there. And I mean, 8 out of 9 cases had prominent suicidal ideation and self-harming. So I won't go through all of that at the bottom, but the vast majority had tried 2 SSRIs as per NICE, and then a few of the others had different combinations of treatments already tried. So, I mean, our recommendations have been hopefully relatively holistic and looking at the whole person. And I've just listed a few of the things that were themes that kind of came out of this in terms of our recommendations that we've given. So just thinking about the individuals where perhaps questions around other diagnoses were also being made, and trying to make recommendations about how you expedite getting that assessment done. Blood testing was another one we've sort of picked out from the notes, and blood tests have often been done, but perhaps not looking at everything potentially. So given advice about what might want to be followed up or done. Obviously, medication is one of the things we give guidance on, and as I said before, we haven't got a kind of a flowchart or a particular formula, and it's quite specific to the individual. But the aim of the clinic was by no means meant to just focus on medication, and so we've looked also at various other things that have included things that have been picked up through kind of the medication and notes review, and other problems that are perhaps contributing as well to the low mood of the person. I'm just trying to think of a few things like acne, and nothing new to anybody really, but just also looking at how that might be separately addressed. So acne, back pain. I think we had an interesting case recently where restless legs was an issue. It was being separately treated with a medication that you know we kind of looked at and thought through as even a potential option for managing other aspects that this person was having, which was anxiety related, which could be contributing to the depression as well. They were being treated with pregabalin for that. So some of the themes that have come out, and again, I don't think any of this is probably new, but it has been interesting to kind of look at the notes in detail and see that even when someone hasn't responded to one SSRI and that's then stopped, there clearly had been some response to a certain degree, which was sort of evidenced by relapse, it seemed, and then another SSRI was trialed. And so really just thinking that actually trying to address people's expectations of what treatment with medication can do and what it can bring, and yeah, managing the expectations of the young person and the family, and it's not trying to make someone happy as such. I mean, Dr. James already touched on this about the interplay of psychosocial, psychological and pharmacological treatments. That's really kind of stuck out for us quite a way, and again a bit about managing expectations of the family, and if the young person is really struggling to engage with one of these, it's possibly a bit hopeful that the others would really be able to achieve what we want them to achieve on their own. So yeah, I think hopefully, and we've certainly had some positive feedback, that putting more than one head together to try and look at a case and come together with some yeah, collaborative and constructive suggestions has been quite helpful. So oops, just some of the outcomes. We've received quite a bit of informal feedback, which has been nice. It's been positive, but we are trying to gather some formal feedback. So we've produced an anonymous questionnaire, and we've only had 9 referrals, but we've had a 30% response rate, which I'm told is actually quite good for surveys, but that does just amount to 3 people at the moment. But largely has been quite positive from those questionnaires. What we did was, it's quite a quick questionnaire to fill in, so if anyone's listening who might still want to fill one in, that would be good. So it's only a 17 question, which might sound a lot, but it only takes about 5 minutes to complete, mostly sort of yes, no, maybe answers. But we've left a bit at the end to try and gather a bit of information about what people might think could improve what we're doing. And certainly it was something we thought about at the beginning of including a psychologist within this as well, to give some kind of detailed recommendations about what might be useful. So just in summary, we have so far delivered this within our existing roles and work time, and it seems to work at the moment. It would be great if we could kind of evaluate the service more fully, but obviously we'd need quite specific, definitive patient outcome measures to get more than just the feedback that we're getting at the moment, which is sort of great because it's supportive to clinicians, but to see what outcome we might be having for patients, we probably need a little bit more thought put into it. And with that in mind, we are hoping to try and develop a network of clinics, similar clinics in other areas, through trying to reach out to other clinicians, other CAMHS services, with the idea of potentially in the future turning that into a platform for research. So I actually presented a poster of just the clinic model last week at our College of Mental Health Pharmacy conference. So yeah, we'll see what comes of that. I think that's it. I think Dr. James had one slide about consultation, so I don't know if he wants to share that before questions. Now I'm not sure how to unshare my screen. Let me see. Oh, there we go. It's been unshared.
Okay.
Tony, did you want to have a few last words? Okay.
Can you see that?
Yeah, we can.
Can you see that?
Yeah.
You see, I don't think we're taught in CAMHS enough about consultation now, and I think Rachel and I really valued this way. I mean, this is the kind of 10 Commandments, as it were. Well, it is the 10 Commandments for effective consultation, but and you can see this as the things you're meant to do, but as Rachel pointed out very effectively, it is heads coming together in terms of, and what comes out in the discussion. I don't think any particular person can actually determine really. It's just the effect of actually putting the minds together. And I think this is a tremendous way of working really, that probably could extend to other aspects of mental health where a person feels stuck. But certainly I think we've learned a lot, and I hope that the other clinicians also have felt similarly. We've had consultant child psychiatrists, but also their colleagues involved. So these, just give you the reference, the slides will be made available later, I think.